Thank you very much, and welcome to this very interesting session. First of all, we have to introduce our next speakers. Dr. Detoraki will talk first about asthma in COVID-19. Please, we can start.
Thank you, Professor Molina. Dear colleagues, good morning from Naples, Italy. So please let me thank, first of all, my dear friend Aikaterini Antonio for her special introduction, and the Hellenic Chest Disease Society for the invitation to participate in this interesting, interacting, and very international meeting. My presentation today is about, sorry, please, one moment. Okay, do you hear me? So my presentation today is about COVID-19 and severe asthma network in Italy. As you all know, Italy has been the first non-ASEAN country to be hit by a very increasing number of COVID-19 patients that reached about 237,000 patients, confirmed cases, and over 34,000 deaths until now. Of course, subsequently, the infection spread all over the world. It became one of the biggest pandemics of the last centuries. As you all know, the infection ranges from clinical presentations to mild to very critical. And of course, the respiratory tract is mostly interested. In this context, patients with chronic respiratory diseases like, of course, asthma, represent a vulnerable population. And in these patients, respiratory viral infections usually induce severe adverse outcomes and, of course, asthma exacerbations. Moreover, in about 5 to 10% of the asthmatic patients, there is an intrinsic disease instability. And in these patients, of course, the control is inadequate despite the optimal therapy with high-dose inhaled respiratory therapy with corticosteroids, LABA, oral corticosteroids, and of course biological therapy as the GINA guidelines assess by step 5. But there is still limited data about the incidence of the disease in severe asthmatics, and of course about the outcomes of the COVID-19 in severe asthmatics in terms of disease type and severity, clinical course, treatment with biologics. To this purpose, the organization of real-life registry-based observatories could offer a unique opportunity to rapidly collect clinical information on the impact of COVID-19 on a large population of severe asthmatics. And this is exactly what the SANI is. SANI is for Severe Asthma Network in Italy, and it is a web-based national observatory collection of demographic, clinical, functional, inflammatory biomarkers data of patients aged 12 years or more with severe asthma, diagnostic according to the ERS and ATS. These patients are recruited by accredited centers. These are usually secondary and tertiary level centers, university hospitals, all over the national territory. So, during the COVID-19 pandemic, all these centers, plus an additional center of the University of Ferrara, have been contacted and inquired to report all their confirmed or suspected cases of COVID-19 among severe asthma patients. And of course, at the end, there was an extraction of demographic clinical data of all reported cases of COVID-19 from the registry platform. additional data about COVID-19 symptoms, treatment, and clinical course were also collected. Only 26 out of 1,504 patients with severe asthma were identified as being confirmed or suspected for COVID-19, and this is, of course, a very low number. Mean age of the patients was 56 plus minus 10 years, and 18 were females. Severe asthmatics were about, of course, a low proportion. And here you can see the geographical distribution of COVID-19 positive severe asthmatics, and of course the geographical distribution of all positive COVID for nasopharyngeal swab all over the national territory. And as you can see, northern Italy, mostly Lombardia, Piemonte, but also Emilia-Romagna, had the most number of cases where the virus spread mostly all over the country. Most frequent COVID-19 symptoms were fever, malaise, cough, headache, loss of smell, and in some cases, asthma worsening. Only 4 out of 26 patients were hospitalized, and only 2 of them died for COVID-19 interstitial pneumonia. Interestingly, no deaths have been reported among the non-hospitalized patients. The mortality rate in COVID-19 with severe asthma was 7.7%, and this is a mortality rate lower than in the general population in Italy, that at the time was about 14%. Between our severe asthmatics with COVID-19, there was a significantly higher prevalence of non-insulin dependent diabetes mellitus. This is the type 2 diabetes, whereas no other comorbidities were more frequent. Comorbidities that often accompany a severe asthma, like rhinitis, chronic rhinosinusitis with or without nasal polyps, bronchiectasis, obesity, GERD, were not frequent in these patients. Noteworthy, more frequently these patients were treated with anti-L5 blocking agents than those without COVID-19. This was about 65% in the COVID positive versus 39% of all severe asthmatics treated with anti-IL-5 agents. Only a small proportion of these patients were on anti-IgE, that is only omalizumab, of course. So, in our large cohort of severe asthmatics, the incidence of COVID-19 was low, and this is in line with the first epidemiological study from Wuhan, in which the prevalence of asthma, allergic rhinitis, atopic dermatitis, or food allergy was not reported at all between the affected patients. So patients with severe asthma seem to be protected from the SARS-CoV-2 infection and also from severe forms of COVID-19. And the possible explanations of, if you like, speculations could be many. First of all, these patients are very worried about viral exacerbations, as they know that these exacerbations can cause asthma exacerbation. So maybe they have acted with major caution, respecting social distancing or, of course, agent rules, and taking their asthma medication. Indeed, there was a significant increase in adherence to inhalation therapy during the COVID-19 pandemic in patients with asthma and COPD. As you see in the slide, there was a 14.5% of relative increase in adherence from the beginning of the year until March 2020. Of course, as we heard earlier, the effect of inhaled corticosteroids or bronchodilators could be beneficial with dealing with the virus, as we have some reports confirming that in vitro studies, the pretreatment with corticosteroids like budesonide and other bronchodilators may have induced an inhibition of the expression of the virus and, of course, modulated the infection-induced inflammation. Moreover, in the asthmatic allergic patients, Th2 inflammation is the major inflammation in severe asthmatics. And these patients have an intrinsic feature that is characterized by low production of AC2 expression that is exactly the receptor, the enzyme that the virus uses as a receptor to enter to the epithelial cells. So it is possible that this aspect could have acted as the protective aspect in severe allergic asthmatics. Noteworthy in another study published by the American Research Severe Asthma Program, in another subpopulation of patients, the AC2 enzyme with the another protein that is the transmembrane protein serine 2 that is used by the virus to enter the cells were more expressed in patients with severe asthma and diabetes. And this is exactly what we found in our small cohort of patients where diabetes was more increased as a percentage. As we saw, a small proportion of our patients were treated with anti-IG, infected patients. So it is possible, we can speculate, given the small number of the patients, that the anti-IG treatment have been protected towards this kind of viral infection, as previous reports suggest that omalizumab can induce increased expression of interferon alpha in infected cells and therefore induce a major protection for viral infections. What about eosinophils? Targeting eosinophils is now possible for severe asthmatics, and we are here seeing the two possible roles and two possible ways to do that by inhibiting IL-5 and IL-5 receptor. In Italy, only two monoclonal antibodies are available. This is benralizumab, an anti-IL-5 receptor monoclonal antibody, and mepolizumab, anti-IL-5, whereas risleizumab is not available. So what is the role of the depletion or reduction of eosinophils in severe asthmatics affected by COVID-19? In fact, we know that eosinophils could have a possible role in immune response towards virus. And previous reports suggest that patients with COVID-19 may have an eosinopenia that is a fast and important depletion of eosinophils in the peripheral blood. So there was a major warning about this kind of drugs in treating severe asthma. But more recent publications suggest that the antiviral activity of eosinophils is unlikely involved in COVID-19 because it has not been ever observed in humans. So the eosinopenia associated with COVID-19 is likely a secondary phenomenon and not yet directly contributing to the disease itself. So we cannot speculate or imagine or suggest that treatment with anti-IL-5 monoclonal antibodies can lead to an increased risk of infection or a severe evolution of the infection during the COVID era. It is very challenging to manage severe asthma in the COVID era, of course, and among the SANI patients of our registry, only a small minority experience symptoms consistent with COVID-19, with a lower mortality rate compared to the Italian population. Among our patients, there was a high prevalence of type 2 diabetes. Of course, major caution in severe asthmatics and the adherence to medical treatment may have prevented from the development of the disease or the severe clinical course of the disease itself. And we can conclude that further and bigger, of course, real-life data are needed to validate the role of biological drugs as preventing or predisposing factors to develop COVID-19 among severe asthmatics. I would like to thank you all very much for your attention and acknowledge Professor Enrico Heffler from the Humanitas University for his data support, and of course all the SANI working group. Thank you very much.